People back to the end. Roll call, you're in a bad person, route, like a shop. Present. Dr. Goldberg. Dr. Jardine. Here. Dr. Dorsey.
Here.
Jimmy Gross.
Here.
Jeff Nielsen.
Here.
Patrick Kenny. Mohammed Yunus. Here. It's simple. I don't know. Hey, okay, public comment. So, the first one was being pronounced community shout. Okay. From United Way.
Thank you. Hi, yeah, my name is Michelle from United Way. Seeing some familiar faces. It's good to see you guys. Just really quickly wanted to give you guys an update on 211. If you guys don't know what 211 is, which I'm sure a lot of people do, but a lot of people also don't. It's a non-emergency community resources referral line that is funded by United Way in our county. It's 24/7. It's through call, text, and chat. It's available in over 240 languages. And it's real people that they're talking to on the other side of the line. Just wanted to let you guys know that, for a while, just to get some history, 211 wasn't as prominent in our community as it could be. Very much so. It was, we weren't happy with the provider that we were using in Bloomington, Illinois, and it just wasn't working the way we wanted to. And as probably some people in this room know, it wasn't as robust of a system as we wanted it to be. But now we're working with a new provider. I was just hired on about 8 weeks ago. I'm the community resiliency manager. And so just wanted to let you guys know that we're really trying to get this system updated and really become a big part of our community. We want people to be able to trust it and rely on it. So yeah, a large part of what I'm doing right now is going around and meeting with a lot of different organizations, a lot of different people. Some of those people in organization, or some of those organizations are in the database for 211, but I'm also getting some people signed up. A large part of what I'm doing is also making sure that the information in the database is up to date. Because, I think one of the complaints that I've heard about with 211 is that when people try to contact 211, they're getting sent information that is out of date or it doesn't make any sense or things like that. So I'm trying to make sure that that is something that is being updated and changed. We're going about creating a marketing plan for this. We also are looking into trying to see, I just talked with the Northern Illinois Homeless Coalition about this, but we're looking to see what it would be like to do like live updates, and likely we can't do it when it comes to vacancy just because of SPO, the single point of entry, but we are going to try to do some sort of live updates when it comes to like housing vouchers and those application wait lists and things like that. So that way we can maybe try to provide a little bit of, I don't know, hope is the word I'm thinking of, but that's not really the right word. But, if people are calling 211 and asking for information and they are being turned down everywhere they go, maybe it could be helpful for them for right off the bat to see, hey, like there's no room for you to apply right now for this voucher, for this housing, and maybe that could be helpful to them. So that way they don't have to go down all these different areas and then be turned down. So those are kind of some of the new updates that we're working with 211. We're really excited about it, and we're really trying to just get the community to really embrace it and really just remember that it is available. There are some people in the community that I know are big proponents of this, and it'd be awesome if you guys here in this room could be proponents of it as well. Like I said, my name is Michelle, and if you want to contact me and talk about it, or if you want me to come and talk to your organization, I'd love to. I'm speaking to the Rockford Public School nurses tonight. I've spoken to a lot of different organizations, and yeah, we just really want to make sure that people know that this resource is available and that it is going to probably within 6 to 12 months become a much more robust and trustworthy service. So that's kind of the timeline we're looking at. But yeah, just wanted to let you guys know that, and hopefully we can all get on the same page. So thank you so much.
Good afternoon, Sadie Cobio with Rosecrans Behavioral Health. I think I've met most of you guys by now. I wanted to pop in and share, I love a good client story and a good win for the community. So I wanted to share that with you. But before I do that, sharing some super exciting news for our psychiatric services. One of our goals as a part of access to care was to reduce our connection time from assessment to getting in to see the psychiatrist, which we officially have under 30 days. I think that is such a gift to those seeking services. We're going to continue to work on that, continue make it something that's even greater, but a win nonetheless to be under our ultimate goal, which is 30 days. So for the better part, which is the story, I wanted to share a story about a client who came into our Rosecrans Harrison location for detox or withdrawal management. After maintaining a year of sobriety, we had a client who came in who had relapsed 5 months after her husband had died. The client expressed depression and anxiety throughout life, compounded with some trust and relationship concerns, and the loss of her husband, who was a grounding presence in her life, led to some significant alcohol use. That downward spiral nearly consumed her until she remembered that there was a space she could go and ask for some more help. She sought treatment because she wanted to reclaim her life and recognized her role in her other people's lives being such a powerful motivator for her. Early on in treatment, she was a little bit resistant, as sometimes stepping into care can be. And she minimized some of the concerns that she had, feeling like her family was the one who put her there, not necessarily the one bringing herself there. She found some connection in group, and by being engaged and building some new coping skills and a voice, she has now stepped into a sober living environment, putting almost 60 days of sobriety into the world for her, and she continues to stay connected in the 12-step community. I just thought I'd share that as a win. I feel like it's easy to talk about a lot of the other things and not so many wins. So something to sprinkle your day with some sunshine. We couldn't do that without you guys. So I just want to say thank you so much.
Yeah.
Thank you. I'm Sergeant Mace with the Rockford Police Department, and I supervise the crisis co-responder team. I'm here today to present data analysis that was put together to essentially answer the question if we maybe needed to change our hours or if CCRT should be working all the time, essentially. The data was collected from 8/1 of 23 to 8/1 of 24. And like I said, the purpose was to analyze and to address the CCRT off hours response, or if hours needed to be altered or changed. So I'm not a huge data guy. I'm not going to go through all of it, but whoops, I guess I'm going too fast already. All right, so the first thing we looked at were the total calls for service. And if you look at the graph, you see the standard hours. So the standard hours would be the hours that we work during the day, and that would be from 06:30 or 6:30 a.m. to 11 p.m. And what we found on the weekdays for the standard hours, right, 6:30 to 11 p.m., the calls for service were right around 1,463. Okay. And then those same weekdays on the non-standard hours or time that we're not working, which would be 11 o'clock at night till 6:30 in the morning, the calls for service were right around 346. So as you can see, there's a difference there of about 76% of an overall decrease of the incidents during the non-standard hours. We also looked at the weekends, which would also be non-standard hours essentially. But the weekends, for when we would be working on the weekends, it was 496. And then the same thing on the non-standard hours, about 143 on the weekend. So like I said, basically saw the 76.4% overall decrease, and then decreases of 42.6%, 30%, and the number of incidents per hour were found for weekdays and weekends respectively. The Winnebago County Sheriff's Office showed the greatest change between standard and non-standard hours. So essentially what that told us, and here's more of a pie chart, a little more of a breakdown, is that essentially during our standard hours is when we get 80% of our calls. Non-standard hours, we get 20% of the calls. And then next to that, they actually broke down the incidents by day. Despite fewer incidents happening during non-standard hours compared to standard, there were still 489 incidents during these times. This indicates that incidents requiring a response can happen at any time and any day of the week, which we obviously realize too. We can sit here and put all the data together we want, but the fact of the matter is that these things can happen at any time. Someone can be going through a mental health crisis anytime during the day or night. The next slide was just showed the stats for an overall breakdown of incidents by event day. The percentage of incidents was roughly identical for each weekday. There were slightly lower percentages were found on the weekend, and then on the weekend, a slight number of incidents occurred on Sundays. So essentially what that told us is the hours we're working are working the best for what we have right now. We're covering the majority of the incidents with the hours that we currently work. So the next thing we looked at is if we're not available or it's not our standard hours, how can we help our officers better deal with those in a mental health crisis or any situation like that? Well, I guess there was some more data. They had the overall breakdown of incidents by hour. Which showed during the weekday, the highest percentage of incidents occurred in the evening around dinner time between 5 to 9. Again, our standard hours. The percentage of incidents decreased between 11 p.m. and 6 a.m., likely because most people are sleeping during this time. On the weekend, the percentage of incidents did not show the same negative trend in the morning. And then a relatively large percentage of incidents occurred at 8 p.m. on the weekend. And then we also looked at the different types of calls that were being received during the standard and non-standard time. And there we found Rockford PD reported the highest percentage of incidents. Obviously, we're the largest agency. We have the highest population, so I don't think that was any surprise. The majority of the incidents involved mental health issues, and this was followed by suicide threats and suicide attempts. So we looked at actual mental health calls, suicide threats versus suicide attempts, seeing that the mental health calls or mental health issues had the highest number of call volume. The next slide just shows the percentage of incidents by incident type grouped by the agency. So again, Rockford PD, led, but obviously that's due to the larger population that we have. The darkest blue was the mental health issues. Again, the suicide threats, suicide attempts, just a different bar graph, if you will. And then percentage of incidents per hour grouped by incident type. So what we found here was mental health issues followed the general incidence trend found for weekdays. High incidences were found at 3 p.m. and 7 p.m. So that's occurred broadly during standard hours with the highest instances at 8 p.m. to 9 p.m. And incidents were less likely to occur during non-standard hours with 3 a.m. As an exception. Suicide attempts occurred primarily around dinner time, 5 to 6 p.m. during standard business hours. The decreasing trend found for the other incident types during non-standard hours was not as clearly present. So again, the data told us we're covering the times when a majority of the incidents come up. Again, we wanted to help our officers and make sure they were prepared to deal with incidents should they arise. So what measures did we take to support officers in managing individuals in crisis during non-standard hours or when CCRT is unavailable? So I went and met with the Northern Illinois Training and Standards Board, who connected me with the Crisis Intervention Training Director of Illinois, and working with them, agreed to actually host 4 CIT classes right here in Rockford in just this year. Typically on a normal year, just due to the logistics and the cost, they would typically only host one CIT class a year. So we were able to get them to do 4 this year, and I'll make that push again for next year. So what that allowed us to do for Rockford was to send, and that number is actually wrong, 45. I looked it up today. We've had 51 officers are either have gone through or are going through the CIT training. It was September, October, November, December. So by December, we'll have 61 new officers, including the officers we already have. And just some quick calculations will be between 65 and 70% of all of our patrol officers being CIT certified. In addition to the CIT training, we're required annually as officers to receive annual training such as mental health refreshers, officer and stress management, cultural competency, and human trafficking. So on top of the CIT training, they're also trained in many other aspects that can be useful in those incidents. In addition to that, our dispatch center was a CESA pilot program and are now a permanent CESA program. So what that means is the mental health calls can be triaged in the 911 center by there's 3 nurses, correct, John? By nurses. So some of the mental health calls that come into the 911 center will be triaged by the nurse right in the 911 center and never even be dispatched to law enforcement or unless it's absolutely necessary. And then they can also refer individuals to 988 or connect them with other resources that might be helpful for them until we're working and able to get a hold of them and take it the rest of the way. And just because we don't do the initial meeting doesn't mean we're not going to follow up, right? So our officers, if they handle these calls, we have a referral program through our new software database, and they're also writing reports on these calls. So those reports are coded to CCRT, so we get them and then we assign them for follow-up. So if the officer can get them through the initial incident and help them through that initial incident, then we can follow up, make sure that they're getting the services and resources that these individuals need. That's all I've got. If anyone has any questions. I'm guessing you did, Terry.
I've had the privilege of working on CCRT last summer. And they really do an outstanding job. And he's right, the hours are different. I mean, if you got another data, because I know that one of our concerns was weekends, mental health doesn't take the weekend off. But I found it fascinating how well they handle it. I was able to go out on certain calls and see it firsthand. Yeah, I think this is a program that we're spending our money wisely, ladies and gentlemen. We really are. And with Sergeant Mason, the rest of the people on there, you have Lost Department, you have the county, you have the city. They're really working well together. And I think Sergeant Mason, your credit to, there you go. Those folks are really doing a wonderful job. They really are. And I'm not reading to be the Reverend Chief Larson who tells me mental health, that the guys too, but just specifically with you folks, guys, you get out, you go out, see it through their eyes. Seriously, not through politicians, I've said to you before, social justice warriors in the media, see it with their eyes. It's a whole different ballgame. It really is. Thank you, sir.
Thank you. A question or a comment. Also, I'd just like to add real quick. So the CI training on Thursdays, they do scenarios. I can get you the dates for those trainings if you'd like to come and see the scenarios. They really do an outstanding job. And they actually fly in actors to partake in the scenarios. And I talked to the director and she'd opened it for anyone on the board that would like to come and experience it or watch some of the scenarios. You're more than welcome. I'll get the dates out to you and then just contact me and we can put it together. Go ahead. I will. Absolutely.
Follow up then the next day. Are those tags, some of those tags so that?
Yes, absolutely. Like I said, so I'm sorry. I'll let you finish. Yeah, absolutely. We follow up on them. Our policy right now is to try and follow up for the first time within 72 hours. So like I said, if the officers anywhere in the county have an incident or deal with a person in a mental health crisis, they can refer them to us. Or if they write a report, like I said, they'll code it CCRT, so that'll come to us. We'll get it assigned and we try and follow up within 72 hours.
Data, ages, what does that profile look like in terms of ages of suicide attempts? And
I don't have that in front of me. I can certainly see if we could pull that, Chief Gallagher, and I can forward it to you, but I don't have it in front of me.
get in touch then with someone? Because obviously we're buying services from agencies for suicide prevention.
Right.
So do they then get referred?
On the attempts? Absolutely. Yes, absolutely. They'll come to us. The officer will respond, write a report. They'll come to us and yeah, we try and connect them with whichever resource we think will work the best for them. Yeah, we do in Gelada. Yeah, we do. And it would be in the notes as well, typically. Sure. Well, I guess that's yeah. Oh, geez. Okay.
That you provided, is there any data on deflection? How many went to jail?
Yeah, absolutely. And I know this because I just talked about it. So program year 4, which you know would have been the last 6 months of 24, the first 6 of 25. We serviced 1,610 unduplicated individuals, and only 3.5% of those ended up becoming involved in the criminal justice system. I don't know that we checked holidays. We could certainly pull that data and see, but it would be, the same. The officers would do the best they could, and then we would follow up to it as soon as we possibly could.
Holidays. So what has been done?
Actually, and not to cut you off, but we don't get the same holidays that I'll say most people or most companies get. A lot of the holidays we're still gonna be working. We get 5, is there 5 paid a year? I'd have to look, but some of the holidays we are gonna be working and are gonna be available. Right, right. We try to present to every group that we possibly can. I get several requests a week to go out and present. So we present as much as possible. We try to go to as many roundtables as we can, as many of the seminars that we can, and just get as much as we can out there. Not offhand, but I could certainly get it from Rosecrans, I would imagine would track majority of that. Yes. Yeah.
Is there? The hospital that we take them to. What do we do if there is an issue with how many people come to be served in the emergency at times?
So we're actually able to work with all the hospitals. The members of my team have been able to make connections with all three of the local hospitals. So depending on what the situation is and what we think will work best for the person, will determine for us which hospital we're going to take them to.
How has it been determined if they need a mental health intervention, like going to the hospital, or if they're going to be arrested, or families with issues?
So essentially, if they've dealt with us before and they're closed out, or we've already done our process, we would reopen them, continue the follow-ups. We've been given some pretty good leeway, I would say, obviously depending on the crime, that we don't always have to make an arrest. I mean, obviously that has to be judged upon the crime, the supervisors working at the time, but we are able at times to say, you know, let's say a criminal trespass ticket is not going to be the best for this person right now. The best for them to be right now would to get them assessed and see how we can help them to keep it from happening over and over again.
Themselves, family members, agencies, community members.
I would say both, but I don't know how we would track that from the 911 center. That would mean probably going. Or a family member.
My question, as a board, our programs were intended to do two things. One, cut down the numbers of people going into jail. Number two, going into emergency rooms. Do you feel that we've got a reduction of people going into local
100% the jails, just in the numbers that I gave you. I would say the same with the hospital, but sometimes the people in mental health crisis, that's where they need to go. Yeah. Yeah. But as far as the jail part, absolutely. I think we've cut that drastically.
Take individuals there directly.
Yes, we will, depending on the situation. Again, obviously there's Rosecrans clinicians and a nurse on my team, so we work closely with Rosecrans, but absolutely, yeah, that's definitely an option.
Those there's conditions.
Yes, there's quite, does someone have I forgot a resource guide, but, yes, they are. There's a large number of them. I can get you the exact number. So what we try to do, if someone reaches out to us or we see that they're a resource, we'll sit down and meet with them, make sure we get the contact information and just see who would best be served by using them. But there is a large number. Chief, go ahead.
For the 1 years, making progress. For the, it's been a lot of years in that job, and so we need to But the one fellow that held, people start to remember wait time, he knows the forest, and
Not necessarily. Sometimes we can, essentially, it just depends on the staff at times. Sure.
Jeff, when I put in the rooms, going in with them, depending on how that situation is, we're attentive right now. It really is like, it's better than us. Better than us. What about you now? I don't know, my case.
No, I mean, there's certainly times where they will, but other times if they're full and a lot of things going on, it just depends on the staff. Yes, sir.
Touched upon the third of that meeting, which is connectivity to ongoing longitudinal service. I heard you say you make connections to, but I think when you give up, I'm not sure this is the question, but I'm not sure you answer. It's not actually determined that ongoing care, the connection that's been made, and is continuing. In other words, the ultimate goal of this would be address a person in crisis, what we prevent from reoccurring somewhere in the world, which means that there's somehow gotten ongoing care.
Right.
I don't feel wrong with that. It would be great to be able to understand the
I mean, I think we could, you could go back and look at just the dates of service versus the individuals entered in the program. It's certainly, right. Right.
giving. Stress. Just an isolated thing you see, how you take care of one person, avoid the consequences and further behaviors like.
Right. At this point, we try our best just to connect them with the services and hope that they continue through and that, they work for the person.
When you don't draw about, you get a call. That's not.
Yes, typically it is. Right on our, we call them a roll call sheet, but they'll have the officer's name, the area that they're working, and then whether they're CIT certified. And it's my understanding that dispatchers, if they pick up that it's a mental health call or a CIT officer is requested, they're gonna send a CIT trained officer, which, like I said, by the end of the year, it will be a majority of the officers in the county, really.
Thank you very much for all the information you shared today. And I know that because of our kind of insinuations that we needed to have this looked at more intently, and you certainly have done that. So we will be discussing your special conditions and see what we can do to remove that, because I think that you've kind of met them. So.
Thank you very much.
Yeah. Somebody in the back did have your hand up. Did you want to ask a question? Did she?
I think they're.
Oh,
He
okay.
was trying to give him information.
Oh, did you want to say anything? Yeah, go ahead. Go ahead. Well, thank you for sharing that. And thank you so much for the services that you offer our community. Okay, we will move on to the monthly activity report, and Jason.
Thank
can
you.
Highlight a few of them.
That was an impressive fielding of questions, by the way, Sergeant. Meeks.
Yes.
So this past month, we really made a strong push right up to the deadline of the grassroots funding to get the information out about that. I think that was certainly demonstrated by receiving 16 proposals that the information had gotten out to the community. And so we just continue to remind board members to get in and do those evaluations, as that's going to be critical for making determinations to go on to the next step, which will be discussed and potentially decided here at the November meeting coming up. Just a couple of other things to have on your radar. Terry and I were fortunate enough to be part of the CCRT proclamation at City Hall to go and support that great program and be recognized by the mayor. And there will be similarly a mobile integrated health proclamation at the coming city council meeting on Monday of next week. So if any board members would like to attend, you are invited to go support that program as well. And if you want to just let me know, then I can share that information about who will be attending. And then another good community event, it is there's mental health awareness.
It's Mental Illness Awareness Week.
Mental Illness Awareness Week. And NAMI is hosting a series of events, and the kind of their big annual one will be on October 10th. They used to have the rally, but they've shifted their focus to more of a sharing of stories of lived experience. And we will have a table at that event to distribute board materials. But certainly if any board members want to attend and show support, just coordinate that with Chelsea, and you're welcome to attend to sit at the booth or to just participate as a community member in the audience.
That's October 10th,
And where is it?
Veterans Memorial Hall.
Okay.
Veterans Memorial Hall from, it's right there, it's 11 to 1.
10 to 1.
Yeah.
10 a.m. to 1 p.m. at Veterans Hall.
Okay, thank you, Jason and Chelsea. Moving on to action items, I need a motion to approve the September 2025 meeting minutes. Andrell, second? Yeah, all right. All right, any corrections, additions? Hearing none, all those in favor, please say aye. Thank you. And the second action item, and I will need a motion, is a resolution authorizing funded program budgets update for programs years 4 to 6. And this involves the Boys and Girls Club. And basically they are decreasing the amount of money that from their budget that goes to Rosecrans because they did not have as many referrals, and they're using the money for direct personnel salary increase. And we need a motion to approve. There's no more money involved. It's the same amount. It's just an amendment. Okay. And Jeff seconded that motion. Any questions, Bill?
It's for social workers, correct? Yes, it's to hire social workers.
Right.
In the discussions we had with them, we were clear, they have not done it.
No.
They have had social workers with MSWs on staff in the past. In the discussion we had with them, we certainly expressed to them the need for a clinical supervision model. And they, I believe, were going to have that as part of their contract with Rosecrans moving forward, or that was my understanding. So that they're, yeah.
So, again, this issue,
Yeah. Potentially.
Yes,
The good news is we have, I think, as, it's a short-term win with hopefully a long-term solution to the problem with development of now local social work programs. We're hoping to really try to connect those academic programs with the hiring of, for our funded programs, but I think that's a continued challenge for every organization across the board.
right.
Interesting for them, mostly also issue like identifying especially as
Yeah.
Right.
We can do that.
Yeah, if they can find something.
So, Jason, you're saying that they do have a clinical supervision piece put in this?
That was the discussion we had with them to put this forward.
Right.
Is there somebody from Boys and Girls Club here? I think there was gonna be a representative from the organization. I don't wanna speak to the specifics, but for every program that the mental health board has funded in which a, let's say, non-traditional mental health provider has hired a mental health staff of some kind to provide a direct service, there has been the expectation and requirement and accountability around contracting for or developing a clinical supervision model so that there are not unlicensed or, people, mental health professionals without clinical licensures that are practicing independently, which would be a violation of professional standards and expectations.
Okay, any further discussion? Motion has been made, second has been made. So at this point, the roll call, Andrell, Bradshaw, Dr. Copeland, Dr. Giardini,
Yes.
Dr. Gorski, Dick Conert,
Yes.
Tim Neighbors, Jeff Nielsen, Dr. Penny, Mohammed Yunus, Mary Ann Abadi, yes. Okay. And we move into discussion items, and this first one and only one is the fiscal year 2025 budget update. And Jason, you
Sure.
take it away.
This is a routine budget update that we have implemented as a quarterly process. And so this will now be through basically Q3 of the fiscal year 25 budget. Just because the lag time, right, of how our expenditures work. We're usually about 3 months behind on the numbers for where we are in the calendar. So through 3 quarters on the fiscal year 25 budget, on a line item by line item basis, there's really nothing that's exceeding the line item amount except for the legal expenses, which we had previously discussed even at the Q2 update that due to some of the challenges over the past year, that did increase the legal budget and the legal costs significantly due to just kind of numerous FOIA requests that came in that needed to have legal counsel review. And then that pretty much is it. Everything else is pretty well on budget. I will say a lot of the kind of operational line items are pretty close to the line item amount, or they're at a good spending level. Insurance is a little lower, but we're expecting that cost again to go up this year. And so in process of working through that with the insurance carrier. But the program expenditures are not significantly, but slightly under where we would want them to be. So when I look at budget utilization, our goal was to get to 75% of of spending this year from what was budgeted. And I'm projecting about 71%. So that's only a 4% variance. But then what's compounding that is that people are still spending a lot of money. And so we keep waiting for that sales tax revenue to flatten a little bit, and that continues to go up. So actually the revenue growth rate ended up, by the time the budget, because the budget was approved before the end of the last year, it ended up being budgeted at 5% under, because the previous year had the same issue where it came in over what we projected. And so we budgeted for flat growth, and then it came in above last year. So what was budgeted was 5% less. And now we actually saw 7%, almost 7%. What is being projected is almost 7% revenue growth with 4% less spending. So that creates, close to a 10% gap there. So the point I'm making with that is that we're fortunate because we're over budgeting intentionally, that we'll probably still spend the amount of revenue that came in for the year. But I don't anticipate that it's going to be more than the revenue. And so the actual reserve will stay pretty flat probably for this year. And I think that probably needs to be one of those key considerations as we go into the 3-year strategic planning update, to really identify what are those large scale projects through which we want to get the reserve closer to target number of about 12 months of expenses in reserve. So just something that we can continue to work on. I can answer any specific questions. I would just like to note, as it comes to that part of it, I know we had also talked about the Miami-Dade jail diversion model and the facility that they have. And I do have some update on that it's looking like January is going to be the next date. And Winnebago County Mental Health Board and connected leaders and constituents are top of the wait list for that. So we'll get kind of first pick of the number of seats we want when those dates get set. So I will share those with you as soon as I have them.
Just a dedicated technology. What can you just?
The grant software is the main purchase there. Yeah. It's about $7,000 a year to operate a professional kind of grant management platform that allows for the evaluations and everything to be done electronically, and the application submissions.
Key performance indicators. There are some amazing numbers on, in terms of when you look at, for example, as fiscal year 22, with the 15 grants managed as compared to where we are now, we're approaching 58.
Yeah.
So, and one of the things that amazes me is the lack of information about, when you look at this and you see these numbers, like we're talking in excess of $20 million a year that this board is putting into county and services. And we still mostly have people who say there are no mental health services in Winnebago. So, is there anything that we can do to in a sense, get more and better information into the community, about where this is?
Well, I think, yeah.
Well, we have 16 proposals, so,
No, I'm saying. Well, I mean, I know. Years of experience, this is it. What people even want to hear. So. It's like.
oh,
The other point, I guess I would point out is, our administrative costs on emulation to do the work that's being done. And I have stayed extremely low. And so, thank you very much. We really appreciate it all.
amazing work.
And you. Happy.
Six, I think. I think it was 56 on the general, but.
Well, even the data presented today is amazing because I think 2008 or maybe even further back than that, 2005 was the first CIT training in, at least with the Rockford Police Department. I was involved in that. And after they began to get any information in terms of, you know, if the CIT officer was able to deflect or whatever, they actually could not track that at all. There was no ability for any tracking such as that. So it's music to my ears, everything that you presented today, because it tells me how far we've come, and the fact that they are taking ownership of it, it's even like, I can't even tell you what it does for feeling that we have come so far since we started because of programs like that. Tim,
would be something that's, or something that we want to, put some, like, advertising budget, to just like get it out there, like, far as, commercial out there, or, social media glass, social media ad, it's not just our social media. Just, just to increase the awareness, just like, I know, example, RMTV does it. I know that we're not trying to get like, use, come purchase anything from us like RMTV does, but they still have commercials, even though people are, maybe, people of us. So, this is. Right.
I'm with you. I would like to see us talk with people or get information about what would be a good, at least to show this. Because when you look at our report, that's put out about what the range of activities that I find is covering, it's amazing. Amazing, but I've been involved with the public mental health since 1966 in this community. And now, I see this as a dream. In comparison, Mary Ann, where we were in 2015.
Yeah.
When, 6 of us sat and really talked about even getting public money. So it's kind of like, holy cow. Sergeant, your stuff looks great. We've never been there. And the same thing with the jail. It's kind of like, to think about the mental health services that go on in the jail, or the mental health service that we put into the domestic violence things, or within rape counseling, or within alternative schools. It's kind of like we're reaching into places that, frankly, public monies for mental health have never gone before in this county. This is the best that it's ever been. And again, what with Bill in terms of saying, is it perfect by doing that? No, but at the same time, do I think the gold standard for the county of Illinois is pretty much here? And I would say, if we're not it, we're a lot closer than where we were.
So if I could suggest, at the last 3-year strategic plan, we added a promotion and awareness.
Right.
Element to the plan that was not part of the first strategic plan, and the board had embraced and decided to take a decentralized communications approach in which we created toolkits, resources, contract requirements for each of the funded organizations, and they have promoted their programs extensively. And I think that has increased the awareness and promotion through every single, and the visibility through each of theirs, and has connected back to the mental health board with consistent branding and messaging. If the board would like to add to that some type of more centralized communication strategy, then we should look at that through the strategic plan update to identify what the intended audiences are, outcomes, and what's being communicated, because there's a difference between also promoting the success of the funding and programming and the availability of care, and balancing that with the availability of care as well, because if you have workforce shortages and if you have wait times, and the board chooses to do a centralized promotion effort that is incongruent with the availability of service for a particular organization, that creates a negative outcome, right? So I think let's put it as part of the focus of the strategic plan. We're going to do a community survey that also asks kind of the question of, to gauge awareness, and we can compare that to the results from 3 years ago and have a little bit more of an objective standard to say, has awareness increased? And And we can add a centralized approach to that if that is what the kind of goals dictate.
I think that's a great compromise.
Yeah, I think the intent for that entire program is to keep it congruent with the core programs, but to scale it down. So maybe the key elements of it, maybe a every 6 month social media post rather than quarterly, things that are scaled down to the capacity of that size of organization, but certainly expectation is to still have that. I'm waiting for legal counsel review of the drafted contract for that program, and I will get that back to the board, but that already had communications requirements in it. So as soon as I get legal review on that, we'll bring that forward to the board for additional feedback and potential approval.
Okay, thank you. Moving on to other matters, Andrell, you.
We just want to get you compensation tomorrow at the election. Communities and Senator Steve Sloan. And in spite of this awareness, Sergeant Mace will be there with you tomorrow. Some flag. And we're talking about speaking on behalf of our board, I am board member. And so I will be taking information with me if I want to make able to speak on the questions about what we're doing, the monies that have been secured, what we're doing with the monies. And so if we can start writing towards our website and our information, as well as inviting individual meetings to become more educated as to what's going on, as opposed to just having feelings and figures about these things.
Sounds great. Thank you, Andrell. All right. We need a second. Andrell? Okay, we have a motion for adjournment.
Appreciate you being here. Can you please take some time, come over and introduce yourself, okay? You like to get to know who's going to start in the month.
Okay,
Mary Ann and know who you are.
all those in favor, please say aye. Aye. Okay. Thank you all.